All right, everyone, welcome. If you're heading into your clinical rotations or starting your practice, listen up. Mastering how to handle medications for patients with kidney issues is, without a doubt, one of the most critical safety skills you will ever learn. So today, we're going to break down the absolute must-know essentials to keep your patients safe.
Think about it for a second. The same exact prescription can literally save a person's life, or it can be the thing that causes serious harm. You're going to be facing this reality every single day. So what is it? What's the one variable that so often tips the scale between a great outcome and a toxic one?
It's the kidneys, plain and simple. Your patient's renal function is the gatekeeper. It decides if a drug's concentration is going to stay in that helpful therapeutic zone or if it's going to creep up into the danger zone. Getting this right, well, it's completely non-negotiable.
So here's our game plan for today. First, we'll talk about the overall strategy. Then we'll dive into the red light drugs, the ones you absolutely have to stop. After that, we'll cover the super important SADMEN's sick day rules. Then we'll explore the three main ways drugs can actually damage the kidneys, and we'll wrap up with how to make smart, targeted dosing adjustments.
Let's be really clear about something. This isn't about memorizing a bunch of facts just to pass a test. No way. Every single rule we're about to go over is a critical safeguard. It's designed to prevent real patients from getting hurt. This is your clinical playbook for stopping preventable, drug-induced kidney injury and toxicity before they happen.
Okay, let's start with the hard and fast rules. These are the absolute, non-negotiable hard stops that are based on a patient's kidney function, which, as you know, we usually measure using creatinine clearance, or CRCL.
I want you to burn this number into your brain. Less than 30 milliliters per minute. Seriously. When you see a patient's CRCL dip below this number, huge alarm bells need to start ringing in your head. You have to immediately pull up their med list and look for some very specific drugs.
And wow, just look at how many common medications are on this list. With anticoagulants like dabigatran, if the kidneys can't clear it, the drug builds up, and the risk of a major life-threatening bleed just skyrockets. For metformin, a drug millions of people take for diabetes, the risk of lactic acidosis becomes way too high. And for an antibiotic like nitrofurantoin, it's a double whammy. It stops working and it can become toxic. This check is an absolutely vital part of your job.
And it doesn't just stop at 30. You've got other drugs with their own unique red light thresholds that you just have to know. Once you get below 15, for example, most of the other DWACs are out. Sotalol, that has a hard stop at 40. Fampredin, which is used for MS, is a no-go below 50 because the seizure risk just gets too high. You have to have these specific numbers locked in. Okay, so far, we've really been focused on stable, chronic kidney disease. But what happens when that stable patient gets acutely ill? This is where the SADMEN's sick day rules are just so incredibly important for preventing an acute kidney injury.
The key word here is dehydration. Picture your patient. They're sick, they've got vomiting, diarrhea, maybe a fever. They are losing fluids fast. Their blood pressure is probably dropping. In that state, the kidneys are already stressed out and not getting enough blood flow. If you continue certain meds at that point, it can be the final push that sends them right into acute kidney failure.
And this brings us to this fantastic mnemonic, SADMEN's. You need to memorize this, and you need to teach it to your patients. Each letter stands for a class of drugs they need to temporarily hold when they get sick like that. You're holding diuretics, because they'll just make the dehydration worse. You're holding drugs like ACE inhibitors and NSAIDs because they mess with the kidney's own defense mechanisms when blood flow is low. Hitting pause on these meds gives the kidneys a fighting chance to recover.
You know, it's one thing to know what drugs to stop, but a truly great clinician knows why. Understanding how a drug actually hurts the kidney is key. So let's quickly look at the three main ways that drugs can cause damage.
It really just boils down to these three categories. Pre-renal injury is a blood flow problem to the kidney. Intrinsic injury is direct damage inside the kidney, and post-renal injury is a blockage, an obstruction problem that stops urine from getting out.
Let's think about the glomerulus, the kidney's filter, like a tiny plumbing system. For it to work, it needs good pressure. Well, NSAIDs squeeze the inflow pipe shut, which reduces flow. ACE inhibitors and ARBs, on the other hand, open the outflow pipe too wide, which makes the pressure inside just plummet. And diuretics? They just drain the whole system of fluid. The end result for all of them is the same. The filter doesn't have enough pressure to do its job.
Now, intrinsic damage is different. This is when the drug acts like a direct poison to the kidney tissue itself. For instance, drugs like aminoglycides can cause something called acute tubular necrosis, or ATN,
by directly killing the kidney's filtering cells. Other drugs, like some antibiotics and even very common PPIs, can trigger a kind of allergic reaction inside the kidney called acute interstitial nephritis, or AIN.
And finally, we have the plumbing blockages. Some drugs, like high doses of acyclovir, can literally form tiny crystals in the urine, creating a physical clog. And then you have anticholinergic drugs that can prevent the bladder from emptying properly, causing urine to back up and put a ton of pressure on the kidneys.
Okay, let's get to our final section. Not every drug is a hard stop. A lot of them just need careful dose adjustments. And this, right here, is where the art of clinical pharmacy really shines, when you're tailoring the therapy perfectly to your patient's individual kidney function.
But smart dosing isn't a one-size-fits-all game. The strategy totally depends on the drug. For antibiotics like aminoglycosides, we extend the dosing interval, giving the same dose but less often, to get a high peak for effectiveness but allowing time for it to clear to avoid toxicity. For a drug like allopurinol, we just reduce the dose. And for others, like colchicine, the risk of toxicity and severe impairment is so high that it's usually best to just avoid it completely.
So, you know all the rules now. You've got the playbook. But the real challenge is applying it. How does the patient sitting right in front of you, say a frail elderly woman with lots of other health problems, versus a stable younger man, how does that change your next move? That's where clinical judgment kicks in. These rules are your foundation, but you always have to treat the patient, not just the number. Thanks so much for watching. For more explainers on critical pharmacy topics just like this one, make sure you subscribe to the channel.